Okay, we are now live.
Good morning. My name's Mike Lodge. I'm the Senior Scrutiny Officer from Calderdale, and I'm starting this meeting because the first item on the agenda is the election of Chair and Deputy Chair. So this is the West Yorkshire Joint Health Overview and Scrutiny Committee, the first formal meeting of the municipal year. Item one is the appointment of the Chair. Are there any nominations for the position of Chair? Councillor Blackburn.
Yes, I nominate Councillor Marshall Cartung as the Chair, and wish you all the very best.
Is that seconded? That's seconded by Councillor.
Second.
Thank you, Councillor Harrington. So that's proposed and seconded. Are there any other nominations for Chair of this joint committee? No.
I propose Councillor Howard Blackburn for Vice Chair, please.
Thank you, Councillor Marshall Catering. Is that seconded?
Yes, seconded.
That's seconded by Councillor Smage and Councillor Hutchinson. Can I put it then? Are there any other nominations for Deputy Chair? No. So can I ask you, all those in favour of Councillor Marshall Catering being elected as Chair? That's anybody against? That's carried. All those in favour of Councillor Blackburn being elected as Deputy Chair, please. Any against? That's carried. So thank you very much, Councillor Marshall, and congratulations to both of you. Councillor Marshall Catton, do you want to take the chair, please? And you are on mute, Councillor Marshall Catton.
Sorry about that. Thank you all for attending this morning. Abigail Marshall Catton is my name. I'm from Leeds City Council, the chair of Scrutiny Board for Adult Health and Active Lifestyle, and the new chair for the West Yorkshire Joint Authority Board. So welcome to all our partners who have joined us this morning. It's great to have you, and we're going to have a quick introduction, and I would start with Mike.
I'm Mike Lodge. I'm the Senior Scrutiny Officer for Calderdale Council, and I provide the officer support to this scrutiny board.
Thank you very much. Councillor Harrington.
Good morning, Councillor Norma Harrington. I'm a Leeds City Councillor. I'm on the Health and Wellbeing Board, and I also sit on the Adult Health and Active Lifestyle Scrutiny Board. Thank you.
Thanks for coming. Councillor Glentworth.
I'm Councillor Glentworth. I'm from Bradford Council. I sit on the Health and Social Care Board and on this one.
Thank you very much. Councillor Blackburn.
Thank you, Councillor Howard Blackburn. I'm a councillor for Big Council on Calderdale Council. I'm also the chair of the Adult Health and Social Care Board in Calderdale.
Thank you very much. Councillor Hutchinson.
Councillor Colin Hutchinson from Skirkett Ward in Calderdale.
Thank you very much. Councillor Smage.
Councillor Smage from Kirklees Council, and I'm chair of Scrutiny in Kirklees.
Thank you very much. Councillor Ramsey.
Councillor Ramsey from Kirklees, and I'm chair of the Adult Health and Social Care Scrutiny Panel.
Thank you very much. Have we got any other councillors that haven't called?
Yes, my name's Kevin Swift and I'm from Wakefield.
Thank you, Councillor Swift. My apologies. Thank you very much. Have I missed anyone else?
Yes, good morning. I'm Councillor Andrew Lee from North Yorkshire County Council.
Thank you very much. Please, could I ask the councillors if you could put your names on the screen as councillor, then I know who you are. Do bear with me, being my first day of the chair, so I do know that you're all elected members, if you don't mind. Thank you very much. Okay, moving on swiftly. Have we got any disclosable pecuniary interest, please? Could I ask members before we start? Can you nod so that I know? Yeah, Mike, would you like to come in? You're muted, Mike.
Oh, sorry, Chair. Councillor Betty Rhodes and Councillor Rizwana Jamil from Wakefield and Bradford, respectively, have sent their apologies.
Okay, thank you very much. Noted. Right, I'd also like to use this opportunity to say a huge thank you to Councillor Grenwood, who was the chair of this board before I came and has now retired as a councillor. So I am sure on behalf of every member of this board, we give her a virtual clap and let it be noted, and please do send our sincere thanks for all the hard work and support that she gave this board. So thank you very much on behalf of the board. Okay. Please, could we refer to minutes of the last meeting, which was taken on the 29th of March, 2022, and that would be on your agenda pack, pages 5 to 12. Are there any issues arising from that, members? Do we want to accept that as an agreed and correct record of the meeting? If it's a yes, I'll see your nod, or just give me a thumbs up or a smile. That would do. Excellent. Thank you very much. Councillor Glentworth, I can see your hands up.
It was just to acknowledge that I agreed with them.
All right. Okay. So it's a thumbs up if it's a yes. And then if you put your hands up, that means you're wanting to come in to make a comment or ask a question. That's great. Thank you very much. Okay. We're going to go straight to our deputations now. And normally deputations will take about 10 minutes. Mike, can I just get you to speak on this agenda if you don't mind?
As far as I'm aware, we've had no public deputations.
Okay. Excellent. Thank you very much. Next on our agenda is West Yorkshire Association of Acute Trust, and I believe we've got members representing and having a presentation with us today. Is that correct?
Lucy Cole is here for this item, Chair.
Okay. Lucy, you're welcome and happy for you to take over.
I've just got a few slides for you, so I will try and, oh, I can't share my screen, Mike.
Bella, can you help, or Sophie, can you help Lucy with that? You should be able to share.
Hopefully you can do.
It's letting me do that now, thank you. Can everybody see those okay? Brilliant. Okay, thank you very much for having us today. I'm going to just give a brief overview of the West Yorkshire Association of Acute Trusts. I'm the director there. My name is Lucy Cole, so thank you for the introduction. My colleague Becca Spavin is going to talk specifically after this about community diagnostic centres, which, as you'll see, is linked to this presentation. So firstly, I noted that my colleague Keir Shilliker, who has a similar role to mine in the Mental Health, Learning Disability and Autism Collaborative, came to talk to this committee earlier this year. So hopefully you'll be able to see some parallels in terms of the work that we do through the West Yorkshire Association of Acute Trusts, as with the mental health and learning disability sector, but equally some differences in how we work. So I thought it would be helpful just first to give a bit of context about provider collaboration, just for members' awareness. So obviously members of this committee will be well cited on the Health and Care Bill and the introduction of integrated care boards from the 1st of July. Alongside when that Act was in as a bill, there was some guidance released by NHS England, which started to describe in more detail the expectations around provider collaboration, and that was released in August 2021. And as you can see from the slide, really, this brings to the fore provider collaboration as a key component of system working, and is just one of the ways in which we can, as a group of providers, work together. What that guidance did was provide an expectation that all providers in the acute or mental health sector would form part of at least one provider collaborative, and that was defined as basically 2 or more providers working together on a range of defined issues. Slightly different for community and ambulance trusts, and should only be part of those collaboratives where it would make sense for the providers and the systems involved. A range of capabilities, as you can see, as an expectation, which is in relation to partnership building, programme delivery on an areas of agreed collaboration, having some shared governance in place, and the ability to put in place some peer support, mutual accountability, and joined up working to support quality improvement. I think the key thing to highlight really is within that guidance, fortunately, NHS England tried to focus on this being permissive rather than prescriptive, making sure that it fit with local population needs and the providers in that area. So just a bit of context in terms of the national expectations around provider collaboration. So many of you might be well aware already, but just a brief overview of what is the West Yorkshire Association of Acute Trusts, or WYAT. Effectively, it's a collaboration of the 6 acute trusts in West Yorkshire and Harrogate. It's been established since 2016, so very much a forerunner in terms of provider collaboration, and one of the very early collaborations that we've seen nationally. So a lot of learning about the work of WYAT has informed that guidance that I've just referenced, and a number of partnerships coming together up and down the country talk to us about the work we've done and how they can replicate some of that. It is part of, obviously, the West Yorkshire Health and Care Partnership. Crucially, we have Harrogate District and Foundation Trust as a member with us as part of WYAT, obviously facing into the Humber and North Yorkshire ICS. So a slightly different configuration in terms of our ICB footprints. However, really important partner within WYAT because of our patient flows between organisations. It's absolutely right that we work together on a number of issues across that footprint. It's only what the trusts do together. Really crucially, I think, to say it's not an organisation, it is a collaboration of those statutory bodies and not a standalone organisation that does things to the trusts. It's absolutely about what we do together. There's a clear vision and purpose, which is outlined in our Memorandum of Understanding. And this is really about us achieving outstanding and high quality acute and specialist healthcare for the whole population, which is consistent, integrated and sustainable. So in terms of doing that, really, then there are some key responsibilities that WYAT takes as a collaborative. The first one, and one of the real drivers that you'll see if you look at our Memorandum of Understanding, is about the ability to share best practice, learn from each other, and ensuring that we are tackling unwarranted variation. And that might be in access, in outcomes for patients, or in patient experience. And by working together, that helps us to identify and also drive down any of that unwarranted variation. We have a number of transformational schemes across the acute sector that we work together on as a group of trusts. And crucially, we support that through a self-funded programme management office. So this is about those organisations that are members, recognising the power of working together and our ability to deliver together, and supporting that through funding of some dedicated support like myself and Becca to deliver on those priorities. One of our real focus areas is around clinical service sustainability. So one of the reasons that WYAT came together back in 2016 was a real recognition amongst the chief executives at the time that even if we had all the funding in the world to support our services, the workforce would always be a limiting factor in terms of our ability to provide services across all sites and in the way that we have been doing over the past few years. So by working together, we've got opportunities to identify how we can make our services more sustainable and ensuring that we're meeting the needs of the whole population. One of the really key mechanisms through WYAT is around mutual aid. And what I mean by that is our ability to assist each other in terms of ensuring that we're offering all the services that and support we need to our populations. And this really came to the fore during the pandemic. So if people remember, during the first and second waves of COVID, we had real pressures in critical care in our hospitals. And by working together through our chief operating officers, we met collectively 3 times a week, led by a chief executive, and ensuring we were using our critical care capacity across West Yorkshire and Harrogate to best effect, and that no patient was without a bed when they needed one. We've carried that through now in terms of our elective recovery and how we're tackling some of the challenges on our waiting lists by ensuring we're able to offer patients a range of choices in terms of where they have their procedures and hopefully supporting them in being seen sooner. And very similarly, in our cancer diagnosis and treatment pathways, ensuring that people aren't waiting disproportionate times in different areas and supporting each other through the capacity that's available to be diagnosed and crucially treated sooner. Equally, we play a significant role, obviously, as the acute sector in the wider Integrated Care Board. So Julian Hartley, who is the Chief Executive of Leeds Teaching Hospitals and chairs the Wyatt Programme Executive, is also the representative for the acute sector on the Integrated Care Board. So bringing all of the work that we do collaboratively and bringing a view from the acute sector into that more collaborative forum across the whole system. More recently, Wyatt has started to lead programmes, whole system programmes on behalf of the Integrated Care Board, and I'll talk a little bit more about that on my next slide. And a real focus around how we prioritise and plan our investments that are available to us as a system. So as a result of some of the legislative changes, particularly capital investment is now available to us as a West Yorkshire footprint rather than into individual organisations. And that drives us to have conversations, make decisions about where those investments are best prioritised to meet the needs of the population. So this diagram shows some of our the collaborative programmes that we're running at the moment. We sort of segment those into three key areas: corporate services programmes, which is back office or support functions that you'd see in any organisation; clinical support, so primarily in diagnostics and pharmacy, and our clinical service programmes, which are specific in this case to that service sustainability work that I've talked about; planned care, which is a programme that we lead on behalf of the wider ICS, working with partners across other sectors; and the West Yorkshire Vascular Service, which I know members of this committee will be very familiar with from the work done in the last few years to reconfigure from 3 to 2 arterial centres based on the recommendation of the Yorkshire Clinical Senate. The other two programmes there highlighted in dark blue are the ones that we lead on behalf of the wider system: community diagnostic centres, which, as I say, Becca will talk a little bit more about in detail, and procurement, which is one we've done together as a group of acute trusts since back in 2017. But again, much broader collaboration during the pandemic has seen opportunities as working much broadly across a range of providers in terms of maximising our buying power, thinking collectively about how we can drive sustainability, and equally about how we best spend our money on procurement locally. So how can we maximise that in terms of local investment and economic value through our procurement activities? I thought it'd be really helpful for this committee just to say a few words about decision making. So I think there's two really important distinctions here. The first is where Wyatt is doing programmes which just affect the acute sector and do not have an impact on the way in which patients access services. So things I've just mentioned, like procurement. We're currently rolling out an image sharing solution, which means we can share the workload in terms of reporting diagnostic imaging. And similarly, we're implementing a laboratory information management system, which again means we'll be better able to report pathology results across the 6 trusts. For those types of decisions, we use our committee in common structure, which is our 6 chairs and chief executives. Because it's a committee in common structure, that group makes a recommendation, which ultimately goes to the statutory trust boards to approve. For those programmes or initiatives where there is an impact in the way in which patients access services, so the prime example here would be the vascular reconfiguration that I've mentioned. What Wyatt does is work with partners to make a recommendation, and ultimately that recommendation will come through to the Integrated Care Board with the appropriate oversight and assurance from committees like this. So just to make the distinction there, we're only as a collaborative making those decisions that don't impact the way in which patients access our services. Where they do, it's absolutely about coming together to make a recommendation to the ultimate decision-making bodies. And then just a quick few words really about how the collaboration also works in tandem with our local collaborations. So as you'd expect, all our members are crucial members of their local places and collaborating across sectors within their local places. We will use our structures and do use our structures to share best practice approaches, and obviously that feeds through into opportunities for either at a place basis or a kind of wider West Yorkshire adoption. Where we're doing those programmes on behalf of the system, all places are represented, so it's not just about representation from the acute sector, it's about representation from all the appropriate sectors. a note really that why it's not about sort of performance management or an extra layer of regulation. If there are issues that are impacting quality, finance or performance, the expectation is absolutely that they'll be resolved through either place-based or regulatory relationships, unless the impact is sector-wide and we need to take a view as an acute sector. I think really crucially here for me is that there's a recognition that pathways to meet the needs of local populations are best designed and delivered at that local population level, and that's through collaboration across sectors. So for things like urgent emergency care, discharge, that's absolutely about our local relationships with primary care, with community care, social care, and the voluntary and community sector. That isn't necessarily the work that we would focus on as an acute collaboration, because the value add from working together comes from that local working with our local partners. And really importantly, because I think there are other models up and down the country, there's an absolute commitment to the approach that we have in West Yorkshire, which is about subsidiarity of place, and that includes the funding flows and the commissioning processes. So there is no change to the fact that those funding flows remain at place unless there's an agreement that we commission something once at West Yorkshire level. So this isn't about the collaborative holding money or doing commissioning activities on behalf of the Integrated Care Board. And then just finally, I just wanted to quick infographic just to highlight some of the types of things we do. So this is from our annual report, which we're about to republish for 21-22. We're highlighting some of the key things that we've done. So as you can see, we've managed through that mutual aid approach to support a number of patients to move between trusts where they've chosen to do so, to have their treatment sooner. That's up to over 300 now. So over 300 patients have chosen and taken the opportunity to move to another trust in order to get their surgery more quickly. 150, we're now up to over 200 radiology home working stations now in the homes of radiologists and reporting radiographers, to enable them to do work that we would otherwise need to outsource to the independent sector, and also have a much more flexible work-life balance in terms of that ability to work from home. We've got over 28 hospitals, both in our region and also in Humber and North Yorkshire, connected now to view images, diagnostic images for patients across those hospitals. So rather than it just being in your own hospital, we can now see that, which obviously supports specialist referral and second opinions. And obviously the 2 arterial centres that you'll be quite familiar with. A few other things on there. One thing I'd just like to say, I think, is the power of having that collaborative helps us to attract investment as well. So last year we attracted over £17.5 million of additional capital investment to support our digital diagnostics programmes. And that was on the basis of our strength of collaboration. The fact that we were already working together makes it much easier to access some of those resources. And that's continuing into this year. So just a real positive about how that collaboration is viewed, I think, nationally, in terms of ensuring that resources are made available to us. So that's kind of the overview I wanted to share with you. I'm happy to take any questions.
Thank you very much, Lucy, for giving us an overview of that. And that has been very helpful. I can see 2 hands up already. Councillor Hutchinson and then Councillor Smage. Over to you.
Thank you, Chair. I've got a couple of questions, if that's all right. One is, as you've referred to, sort of the NHS England says that non-NHS providers should be part of provider collaboratives. You mentioned ambulance trusts and community trusts as not being involved with the West Yorkshire Association of Acute Trusts, but you didn't mention anything about non-NHS providers. Are any non-NHS providers included within Wyatt at the moment, or likely to be included within Wyatt in the coming year?
Thanks, Councillor Hutchinson. So no is the straightforward answer. So there are no independent sector providers as part of the collaboration. It's very much those 6 core providers that I mentioned. We do obviously work closely with our independent sector providers through particularly our work on planned care and elective recovery, ensuring that we're using that capacity to best effect, but they're not a part of the formal collaboration. And I think if you look nationally, it's quite unusual that there are non-NHS providers engaged in these types of collaborations.
I mean, I'm sure I'll come back to that with the community diagnostic centres and how those are being arranged. But as you said, a collective approach to delivering clinical services sustainably suggests making best use of that most scarce of resources, which is specialised experienced clinical staff. This committee has obviously considered various reconfiguration plans, and non-surgical oncology is the latest one. So I wondered, what is Wyatt actually actively considering beyond non-surgical oncology at the moment, that we, so that we can actually coordinate the work of this committee with Wyatt's plans in a timely fashion, because that I'm afraid that hasn't happened before.
Thank you. So non-surgical oncology, as you'll be aware, is the active one at the moment that's under consideration. We're just doing a piece of work at the moment to identify if there are potentially any other specialties where we need to look at that. What I would say is that the commitment is about moving patients is the last resort. So this is about how can we have a workforce in the future that might be better utilised across our range of providers. So actually thinking we've moved more and more to a model of having joint posts, whereby consultant posts are employed by a couple of hospitals, so working out in a district general hospital environment, perhaps doing sessions in a specialist centre like Leeds. So that's about making sure that we've got sustainable provision across our sites rather than looking always to reconfigure services. So as I say, that's a piece of work we're looking at the moment, and particularly in terms of our waiting list recovery, to identify if there is further work we need to do in any specialties of that ilk. So as soon as that piece of work's completed, we'll be happy to share that with this committee in terms of how that impacts the work plan.
But if there is anything on the horizon, we would really welcome early sight of that rather than when it's a fait accompli. One final thing, if I may, about medical workforce. In terms of collaboration across the trusts, is the collaboration taking place, and what sort of collaboration in making sure that there is sufficient foundation year training posts for new medical graduates, because across the country that hasn't happened this year, and the specialist training posts to meet the requirements, the workforce requirements. So things like radiology, where we know that there's a massive problem, dermatology, but there's many other specialties where there is a mismatch between the number of training places and the shortfall in clinical staff. So will it be, I know you can't sum it up in one sentence, but where can we find out what is actually going on?
So there is absolutely work in that space. So we have an active group. We have a number of active groups across Wyatt. So particularly with our medical directors and our HR and workforce directors looking at this. And one of the big conversations at the moment, Councillor Hutchinson, is about exactly this, and more about how, as such a large collaborative covering a population of 2.7 million, we could effectively influence national policy, influence Health Education England, and influence the deanery in terms of making sure that we've got that pipeline through. Quite right that you've called out medical workforce specifically, but equally we recognise that we've got a number of challenges in our non-medical workforce and the other clinicians in our hospital. And again, looking at a range of interventions, particularly around opportunities for new roles. opportunities to bring people into the healthcare sector that perhaps haven't worked in the healthcare sector before, through career pathways, and also through a kind of a sustainable international recruitment approach. So, you know, as I mentioned, workforce is, you know, top of our list in terms of the things that we work together on. And as you quite rightly say, a number of specialties where we've got particular challenges, where we're looking at particular interventions around that specialty. So as you said, radiology, for example, is one that we've done quite a bit of work on, in terms of not only ensuring that we've got a pipeline of radiologists, but because of the level of subspecialisation that we now have in the field, that we've got enough coverage in each of those subspecialties, as well as total numbers of staff.
And please feel free to, I'm sure the chair will agree, that feel free to engage with this committee to seek support for those efforts that you're making. You know, but to give that support, we really need to know what is going on and where the gaps lie. Thank you.
Absolutely. Thank you very much, Councillor Hutchinson. Obviously, your experience in this sector is always very valuable for us. So thank you so much. Lucy, just on that last statement, speaking about radiologists that you mentioned, and I do see from the chat, you have about 150 stations that's working from home. Is that correct? Is that just for interpreting results, or do they actually see patients at home as well?
That's for the interpretation of results. So that's what we would call reporting. So we've got obviously patients still coming into a number of places in order to have their scan. And this is about our ability to manage all that kind of results reporting and manage that between us, which is the key, rather than being reliant of that being done within a workforce cohort in the individual trusts.
Okay, excellent. And one more question still on what Councillor Hutchinson asked in terms of workforce. What is your gap? Because obviously we are aware that a lot of different sectors within the medical industry are very, so in real terms, are you able to actually tell us what you're struggling with in terms of the challenges, so that we know, instead of just having a general understanding that yes, we have challenges.
Yeah.
What exactly are you struggling with?
I can't give you the totality of the figure across the board, but we've specifically identified a number of specialties which are in line, as Councillor Hutchinson has said, with some specialties nationally. So ear, nose and throat specialties, for example, also in neurology and in dermatology specifically, so and radiology, as we've mentioned. So there's some specific areas that we're working on, and then I'd say obviously I think it's well documented in terms of our nursing shortages nationally, absolutely sort of replicated in West Yorkshire, and particularly I think highlighted will be around theatre workforce. So given the work that we're doing on recovery of surgical backlogs, and as Rebecca will come on to talk about in terms of some of that acquisition workforce in terms of radiology, our radiographers coming through are some of our main pressures. Obviously what I will say is that can change quite quickly. You know, it only takes a few consultants to retire or move to new posts to create some fragility in the system, whereby we had stability previously. But I'd say there's some of the sort of top headline areas that we're working on at the moment specifically.
Thank you very much. Councillor Smage, over to you.
Thank you. Can I just ask about your governance structures, your committee in common? Because I've been trying to look for paperwork on the committee in common, and there isn't anything on your website. So I wonder if you could help us as to how the decision process is carried out with the committee in common, please.
So we have as beneath the committee in common, we have what we call a number of assurance groups, which are effectively made up of functional groups within the executive of the trusts. So we have scrutiny from our directors of finance, from our clinical, so our medical and our nursing leads, from our digital leads, and from our operational leads, from our chief operating officers. Before that gets to our chief executives, That then goes to committee in common, which is our 6 chairs and 6 chief executives. The role of that committee in common is to support the overall recommendation. So if there's a business case, for example, we look for that committee to support the overall recommendations of the business case. Because it's a committee in common model, the ultimate decision lies with the individual trust boards as the statutory bodies. So it's then up to the trust boards to take that through their boards and ratify those decisions. So at the point at which all 6 of the trust boards have formally made that decision, then that decision is carried.
Thank you. I wonder if it's possible for scrutiny then, because your diagram says the Wyatt recommendation then goes to the ICB, presumably for the West Yorkshire work. You're saying it also goes to the individual trusts for decision. But I'm wondering where it's best for scrutiny to engage, because as my colleague Councillor Hutchinson has said, it's better to have early sight of plans in order for us to be able to engage at the appropriate time. And I wonder if it's possible to have things like work plans, etc., or minutes or something to the scrutiny committee, so that we can see where you are with things and see what it is that we would like to scrutinise, and do we need to plan our work plan going forward, because really it's a little bit late when the decision is going to either trusts or the ICB for those discussions to happen. Those discussions need to happen a lot sooner. So I'm wondering how we can get the information in order to be able to do that, rather than Wyatt being seen really as a body that is not very transparent and is not easy to scrutinise. How we can change that. Thank you.
No, I completely appreciate that, Councillor Smage. So what I would say is what I was trying to just draw through on the diagram was the kind of, if you like, the business end of the decision making. Obviously, a lot of the work is kind of long lead times in terms of transformation work. So my absolute expectation is that anything, as I've said in that has an impact on the way patients access services. So Councillor Hutchinson identified non-surgical oncology, and I know there's been very early conversations about the inception of that work. My expectation is, and we have a framework that sits behind this in terms of, if we believe there'll be an impact on the way patients access services, that there will be early discussions through this committee. Quite happy to have a conversation either as a group or with the chair about our current work plan and identifying if we think there are potentially any areas that this committee would see as suitable to scrutinise in that way. As I say, a number of the things we do are about things like digital implementations, which, kind of core trust business in terms of we've decided to purchase a digital solution collectively rather than do it as individual organisations, and it's about our oversight of that implementation. So I think it's making sure that we get the right things through this committee, but equally, as you've said, getting them here early in terms of that engagement. So I think that diagram's the kind of the very end of the process. I think there's a huge amount of work going in before that, and that's where we need to be making sure we're having a dialogue with this group.
It would be useful if we could have that dialogue as a collective, I think, because then for the various councils to know what's going through Wyatt and what's coming through their scrutiny workshop, the scrutiny committees as well, and where they need to engage with their trusts and where they might need to engage on a West Yorkshire basis. It's a sort of at the minute it's a balancing as to where you scrutinise, and I think it would be good if we could have that as a committee, so that all the council areas can see what their work programme is and what the West Yorkshire work programme is and how they fit together. Thank you.
Thank you very much, Councillor Smage. Very helpful, and thank you, Lucy, for your response. And I'll hold you to that. Definitely, we'll be contacting you, because obviously, as much information as we can get, that will help us in our individual roles as well as our collective role with JOSC. So thank you for that. Any other comments or questions to Lucy before we move on to the next agenda? Are we all happy? A smile will be great. Fabulous. Thank you very much. Okay. Right, and thank you for that presentation, Lucy. Next on our agenda is still Wyatt, so it will be the update on the West Yorkshire Community Diagnostic Centre. And I believe we have, is it you, Rebecca?
Yes, it is.
Will you be yourself presenting?
It is. Could Bella also help me? Because unfortunately, I'm getting the same message about sharing my screen.
Right, our Bella is very kind. She will help, don't worry. Thank you.
Okay, you should be able to share now.
Okay, just one moment, sorry. Okay. So I'll just get it on to full screen and just check that everybody can see that. Great, thank you. So hello everybody, my name's Rebecca Spavin. I just wanted to grateful for this opportunity to update you on our plans for the community diagnostic centres in West Yorkshire. And what I wanted to try and do in this presentation was to just provide a bit of context and background to the programme, what our process has been in West Yorkshire around the development and governance of community diagnostic plans, because as to date there's been no approval of our plans to take forward so far. Just to summarise what our strategic intentions for community diagnostic across our West Yorkshire places are, and then to go into a bit of the next steps and a conversation about what we'll be doing. So what I wanted to share on this slide was just that I think we all recognise that there's a rising demand for diagnostic services across the country, including in West Yorkshire. And community diagnostic centres were part of the Sir Richard's review of diagnostics back in 2020. And he suggested that these be established to support providing diagnostic capacity away from the acute setting, so that there was an ability to separate that sort of acute urgent diagnostic need within an acute setting from what would be planned and elective diagnostics out in the community. So CDCs will be improving the access we have to diagnostic capacity to hopefully reduce the delays that some people have, particularly with the rising demand. And they'll be offering a broad range of diagnostics, so checks and scans and tests away from, as I say, the acute facilities. The circular visual on this slide sets out the 6 aims of community diagnostic centres, and one of the things that strikes me is it fits really well with the West Yorkshire ambitions for improving access, outcomes, reducing health inequalities. So these are a positive thing for our populations across West Yorkshire. So as I say, it's a national programme and initiative, and it's been part of the NHS guidance planning that we have, that all ICBs have community diagnostic centres within our places, and that comes with funding to support that as well. So nationally, there's an aim to have at least another 100 additional community diagnostic centres in England to increase diagnostic capacity. And we've been asked to create 3-year plans for community diagnostic centres by each ICS. So that's what Wyatt, as Lucy described earlier, we deliver some programmes on behalf of our ICB, and community diagnostic centres is one of that. So we have access in West Yorkshire over the next 3 years to circa 52 million capital to support these community diagnostic centres, and that's the work that we're facilitating at a West Yorkshire level, but very much delivered and planned at a local place. So what I wanted to share with this slide is this is nationally some of the pathways, some of the services that we believe can be delivered through community diagnostic centres. As I said earlier, that there'll be a large range of tests available. So it will include imaging tests, so X-rays, CTs, MRIs, and plain X-rays. There'll be pathology tests, so things like phlebotomy, and there'll also be physiological tests, so things like spirometry, blood gas functions. So these are what people feel from NHS England, the national guidance we can or could deliver in a community diagnostic centres. And I think what we're trying to do locally is also, you know, sort of review that against our local priorities and what our local populations need. And so there's a real opportunity to do that sort of planning around these offerings here. So we've certainly been having discussions locally around, as well as sort of, you know, focusing on cancer pathways, breathlessness, long COVID, etc. What other opportunities have we got outside of perhaps sort of diagnostic tests that would fit with these pathways and priorities? So we've been having conversations around frailty, around DVT clinics, around virtual wards, because I think that there are those opportunities as we go forward in the planning and the delivery of community diagnostic centres. So this slide, what I wanted to do here was sort of set out the development that we've been doing at a local place level to come up with plans for community diagnostic centres. As I said, it's very much led at a local place level, and it's really about building on what is the population's need. So we've been considering things like, what are the current waiting lists? What areas have we got backlogs in? What areas have we got issues around sort of inequalities and access? And what future demand, what growth do we need to be providing in our diagnostic services? So we've undertaken what we've called feasibility studies in each of our West Yorkshire places to understand that current activity local demand, to then build what might the best model and provision be for the community diagnostic centres. We've also looked at the social demographics. We've had a real focus on, as I say, analysis of our health inequalities, the waiting lists, and those hotspots areas, and I've got a slide later on about that. We have also, you know, had consideration on, based on that required growth in activity and the demographics, what estate and what location would offer the best access for community diagnostic services going on. And then we've also been considering, building on that, the previous slide that sort of sets out the priority pathways, what do we need for our local populations within community diagnostic centres, and balancing what the national guidance and minimum asks are along that, what we need locally as well. So this slide, it's just a sort of visual representation of some of the excellent analysis that colleagues across West Yorkshire have been able to do. So people that have been working at that local level on community diagnostic plans have also been supported by the West Yorkshire Health and Care Partnership Equity Fellows, and a number of them have been doing projects around community diagnostic centres and inequalities. So the slide that sort of set out what the 6 aims for community diagnostics were, there were those 2 about improving health outcomes and improving health inequalities, and that's what we wanted to do with this analysis. So the red and the yellow colouring on the left-hand maps shows the areas with the highest density of people that are waiting for diagnostic tests for all demographics. And then the red and the yellow on the right-hand map shows the areas with the highest density of people waiting in the most deprived 20% of the population. So that's offered us a real, you know, real-time data and evidence about sort of supporting where we can place community diagnostic centres to support improving those health outcomes and inequalities. So I wanted on this slide to sort of go through sort of building on what Lucy was saying about that sort of the process of how we work at a place and also a West Yorkshire level to developing our community diagnostic plans. So Wyatt, via myself, lead on a diagnostic programme on behalf of the West Yorkshire Health and Care Partnership. Places have led on the development of their assessment of need and via those feasibility studies, and they've also led on what capital and revenue you would need to deliver the plans. At a West Yorkshire level, the community diagnostic plans have been endorsed by the Wyatt Programme Executive and also a West Yorkshire Diagnostic Programme Board. And because this is working, we're delivering this on behalf of the ICB. We've also been to West Yorkshire ICB governance boards, so capital estates and strategies. But what they're doing is approving the financial split of that capital that's available to us. And then they've delegated the approval of place-based cases to place-based committees of the ICB. So very much I see my role in Wyatt as around providing coordination and consistency across our West Yorkshire CDCs where it's appropriate, and to sort of support on optimising how we deliver them going forward. It's very much, though, led, as I say, the detail at that local place. So this slide sets out just a summary of what we're looking based on the feasibility studies for the sort of strategic intention long term. As I said, we've been asked nationally to set out plans for community diagnostic centres over the next 3 years. So Calderdale, Kirklees and Wakefield have been working together, and their intention is to provide community diagnostic provision across those 3 places within the areas that I've set out on the screen. So Huddersfield, Wakefield, Todmorden, Halifax, Dewsbury, Castleford and Hemsworth. Leeds have been working with their partners within that ICB, and they're looking to upgrade Seacroft to provide the community diagnostic centres and to provide further diagnostics within Armley and Beeston, and utilising current void space to do that. And in Bradford District in Craven, the preferred option being taken forward is to upgrade Eccles Hill and to provide mobile provision, whilst further work is done into providing more community diagnostic centres within the Keighley health and wellbeing development and also the Squire Lane. But that's obviously further down the line, and we're currently working on our 22-23 plans, but this is what we're looking at to get plans through, business cases through over the next 2 to 3 years. So this is a visual representation of where the proposed CDC provisions are across West Yorkshire. I'd like to apologise. I have now been told that this is an out-of-date map, and I will update it, so apologies for that. But what I'm trying to do is just sort of show you that in that West Yorkshire role, one of the things that we should be doing is making sure that we're not sort of huddling up provisions because we're doing this in isolation, and so that we've got, you know, CDC plans just across each other's borders and boundaries, because patient choice will allow people to go to community diagnostic centres across our West Yorkshire place, and that's and also that, just as we were saying, we touch on other ICBs, and we're working across the North Eastern Yorkshire region and Greater Manchester to understand their plans as well going forward. So around this programme going forward, as you'd expect with something of this side, there are a number of risks alongside opportunities that this investment offers to our system. That very much what we recognise is that workforce is one of our major risks to the delivery of the additional capacity within community diagnostic centres, and that's something that therefore we want to sort of focus on collaboratively across West Yorkshire, but again also potentially we're with our neighbouring ICSs on, because they're also developing their plans. So everybody's been looking at workforce to going forward for delivering this in. But I think very much that this is about supplementing and supporting the diagnostics we already have within our acute sectors, providing them closer to people's place of residence in our community settings. And I do think that there are a real opportunity to support and develop our services within each of our West Yorkshire places. So the final slide I have before opening up to comments and questions was just what are we doing next going forward. So very much the process has been about that sort of the planning, so those feasibility studies, identifying what our need is, and to secure the investment to deliver those plans. We've not yet had that approval for the investment, so we're still working through that. But our next steps would be around, as I say, working up the detailed pathway delivery, undertaking further engagement, working up what our pipeline is, particularly in imaging, echocardiology, around delivering this additional activity in CDCs. And so a real key next step will be about that recruitment and retention of workforce, new roles, growing our own international recruitment, etc. going forward. So I'm going to stop there and see if there's any questions or comments, please, if that's okay.
Thank you very much, Rebecca, and that is very welcoming to hear about the plans on the diagnostics, and I will say very, very much needed, especially looking at the figures that you have just given in terms of waiting times. My first question before I pass on to members, on your waiting list of 41,700, how long is that waiting list? So when you say waiting list of 41,700, how long have they been waiting for?
I'd need to go and find that out, because that's analysis that other people have done. Is that something I can take as an action and get back to you, if that's okay?
Yeah, sure.
Yeah,
okay. Councillor Hutchinson, he's always my first.
Thank you, Chair. I'm intrigued by the heat maps that you showed. What are Bradford doing that means that they've got no one who's delayed in diagnostic tests? Are they doing brilliantly? And if so, can we roll that out to the rest of West Yorkshire? Or is it that there was no
data wasn't available in the format we were required to undertake that heat map? So we're working with Bradford District to get that data so that we can repeat that exercise. So sorry I didn't make that clear when I presented that diagram. It's a really helpful clarification.
Okay, I thought they might have had a secret. I don't understand what goes on at a hub and what goes on at a spoke. Can you walk us through the experience of a patient from the onset of their symptoms to the initiation of treatment, and where the CDCs fit in? Where are the detailed histories being taken, differential diagnosis being made, a decision about the most appropriate tests taken? And once the tests are done, how do they get put together into an overall clinical picture to decide what treatment, if any, is required?
So the guidance around community diagnostic centres for hubs and spokes, a hub has to provide a minimum set of diagnostic tests in imaging, pathology and physiological measurement. A spoke needs to provide tests in imaging and at least one other diagnostic test, and obviously they're then built up around what is the population need for the proposed plans. The intention is that people can be referred into a community diagnostic centre, as they currently are, into an acute setting by either GP, community service, or overflow from the acute site. So very much one of the things that's key to making this work is that sort of digital connectivity between the referrers the already acute setting and community diagnostics, and that's one of the things that we want to work on at a West Yorkshire level. So the staff will be, you know, elective diagnostics will and can continue at elective acute sites, and people can choose to go to those as well as a community diagnostic centre. So it should continue to be provided as it currently is. But I think what one of the opportunities with reviewing of the pathways is what tests make sense to bundle together, so that you're not having individual appointments for, as you're saying, a phlebotomy and then an ECG, and that offers us hopefully some opportunity to review staffing and how those services are provided. Further work is required, Councillor Hutchinson, on the pathways and the flow through of those, and that's why I suppose we've been given that indication of what our priority pathways should be to consider.
And for people with limited mobility or limited access to transport, are the proposals that transport will be available, will be provided to get people to these testing sites, as currently happens if it takes place on acute hospital sites?
I'd need to check that. We've certainly, our feasibility studies have been very much built on that sort of, you know, proximity to public transport routes, length of time to get to a facility. I don't know the answer about that sort of the transport being available. So again, that's something, if it's okay to take away and come back with the correct answer.
I'll disappear for a moment then, but I do have other questions.
Okay, thank you.
Thanks.
Thank you very much. I'll come back to you, Councillor Hutchinson. So, Councillor Harrington. You're muted.
A couple of questions, please. First of all, having a look at the map of where these hubs are going to be, I particularly obviously have a keen interest in the very northeastern section of the map, but also noticed that Kirklees seem to have a bit of an issue as well, in that most of the red dots are across the middle. It's the middle band across the whole of the map. So those people living in the very extreme outer rural areas are going to have major problems in accessing those hubs. So the picking up on Councillor Hutchinson's last point about transport, if you live in the outer northeast of Leeds, you have major problems in connectivity because public transport is non-existent largely. And also, what is the connectivity with Harrogate? Because we heard in the previous presentation about the linkages between the Harrogate Trust. So a lot of people in the outer northeast of Leeds actually would elect to go to Harrogate. Yeah. So can you tell us what linkages there are there? And my final question is, what kind of consultation is being taken with the public and healthcare operatives to actually inform your decision making? Thank you.
Thank you. So as I say, the feasibility studies had the detail in around those that sort of the access times, the waiting lists, and sort of supported that sort of guidance of where you know, additional capacity was required based on this. I think, as I say, we certainly they had to take account of accessibility to you know, public transport, car parking. And we probably need to provide you a bit more detail via the local plans on those. You rightly mentioned Harrogate, so patients have a choice to cross borders within West Yorkshire, but also outside of West Yorkshire. So the Harrogate community diagnostic plans have been worked up with our Humber and North Yorkshire colleagues, and we've certainly sort of Leeds-based colleagues and Harrogate-based colleagues have been discussing what they're planning, where they are in that recognition of the patients will choose to flow between the two on those. In terms of the consultation consultation. We've worked up the feasibility studies, had a sort of stakeholder engagement process, and we want to continue that with these plans as we go forward, and that we see are very much driven by those local place planning sections. There will be some things that will naturally offer themselves to be doing engagement on a West Yorkshire wide level, but as these are being developed and delivered at place, that's where we'd want to see that work being done. Thank you.
Thank you very much. Okay, Councillor Smage.
Thank you. Can we just explore community settings for a little bit? So can you tell us in Calderdale, Kirklees and Wakefield, where the hub and where the spokes are going to be? Because at the moment it looks very much from your map to be on the hospitals and health centre footprint. So can you tell us how that's going to work, please?
So I think there's across Kirklees, Calderdale and Wakefield, there's very much a mix of estate. None of the current provision is planned to be on any of the acute hospital sites. So the guidance for community diagnostic centres is that it's the preferences that they're delivered off an acute site. If they are on an acute site, there's certain parameters around that, and obviously built on need. So there's a range of identify. We're working through what the estate options are. We're looking, as I say, at void estate, at retail estate, and also sort of the opportunity to lease settings that are already available. So but it as you say, it isn't on an acute car park plan at the moment.
Okay, thanks. So if we could have that information, that would be really good, as well as the transport information, so we can see how easy it is for people to get to. And also, if you don't have the workforce for your hub and spoke models, is it just going to be a retreat to the hubs, or how are the spokes going to operate if you have workforce problems? And also about patient choice. So at the moment, there's not a lot of choice for appointments. You get a letter and you go to either Huddersfield or Calderdale or Dewsbury or Wakefield or Pontefract, depending on where the service is. So how will people have that patient choice? Will it be choose and book, or what will it be? Thank you.
Thank you. So if I start with that patient choice aspect, I think because there is a minimum expectation of what will be provided within community diagnostic provision, there will be that opportunity to choose sort of a number of places to go to, and we've got to work through that. But the aspiration is to have a regional booking system along the lines of choose and book. And that's part of the funding that we've put into our business cases to deliver that, so that would offer that opportunity for people on referral to make that choice to go there. And I think you're absolutely right, Councillor Smage, around workforce, that what we don't want to do is to destabilise acute provision, because people come out and work at hubs, and that's why we need to work out, as we were discussing earlier, what is our gap around these plans, and what are our options to grow our own, to deliver services in new ways, and to have sustainable international recruitment around that. And I think it will be about building up to being additional capacity as these provisions are put online and get to 100% capacity. We're looking at other areas that have implemented community diagnostic plans as stuff that we can working processes we can look at. So they're doing rotations between acute and community settings for their staff, so that there's not that sort of burnout or what, you know, you work 100% at one or the other. So there's those things that we're working through, and that's, again, we've got to sort of you know, utilize our local expertise of people that are already delivering services in what's realistic and manageable, but going forward. Thank you.
Okay, thank you very much. Any supplementary comebacks with that, Councillor Smage? You good?
No, I think if we could have that extra information, that would be really helpful for us. Yes, thank you.
Thank you very much. Councillor Swift.
Yeah, first of all, thank you very much indeed for a very full presentation. You talked about cross-boundary movement. Does that apply with South Yorkshire as well?
Yes.
They are. I hadn't come across this term community diagnostic centre until today. Well, until we got the papers for today. But is that the same thing as the one that's going ahead in the Glasshouse Centre in the middle of Barnsley?
Yeah, so the Barnsley Glasswork, as you say, is one of the community diagnostic provision that South Yorkshire's establishing. Yes. Thanks.
You mentioned a figure of 52 million capital. Was that for West Yorkshire?
That's the totality for West Yorkshire, yes.
Right. Yeah, thank you very much indeed. Thank you.
Thank you.
Thank you very much. Okay, back to you, Councillor Hutchinson.
Yeah, thank you, Chair. We've got capital funding, or hopefully we will have capital funding, but there's significant revenue costs for increasing the diagnostic capacity across West Yorkshire, particularly, as you say, we haven't even got enough radiographers to man the MRI and CT scanners that we currently have within the acute sector. And if we're going to have more scanning machines in the various hubs and spokes, you can't run them without radiographers. So I was wondering how the revenue aspects of these plans were being addressed.
So again, apologies because this was an oversight. We do have associated revenue for the next 3 years alongside that capital offer. So and then what we're wanting to develop at that West Yorkshire level are, plans that are sustainable once but those 3 year allocations of both capital and revenue are utilised. So we do have support for delivering this from a workforce revenue perspective for the next 3 years, but what we don't want to do is make it unmanageable going forward, and that is being taken into consideration.
And can I seek clarification of which organisations will actually own the community diagnostic centres, its equipment, who employs the staff, and where does the clinical responsibility lie when things go wrong, when things are missed or mishaps occur?
Mm-hmm. So a community diagnostics centre has to be hosted by an NHS organisation. So the clinical responsibility and that ownership, the regulatory aspects, etc., remain under the auspices of our acute trusts.
Okay, so staff are employed by the trust.
Yes, but we are looking to work with partners across. So we talked about the independent sector. There will be opportunities to work with the independent sector, but the ownership of the hub and the regulation aspect will remain with the NHS.
But training new staff is almost the independent sector doesn't do that.
And that's one of the things that I think is an opportunity, is that this will increase the places that we can do the training in, and the CDC planners are already in talks with HEE and our local universities across West Yorkshire about what opportunities we could provide for increased training, student-led clinics. So very much that's part of sort of delivering for the NHS family.
absolutely, because as you've said, what we can't afford to do is to strip out trained staff from the acute hospitals to staff this additional facility. Thank you very much. But I'm sure we would really like to know a lot more about
detail
progress on the staffing aspect of this.
Yeah, that's helpful. Thank you, Councillor Hutchinson.
Definitely. Thank you very much, Councillor Hutchinson. Councillor Swift, back to you.
I think it was just a rather whimsical observation rather than anything else. I just note that the map saying proposed CDC sites, it's got the pre-1974 local government units on.
That's my error.
Right again.
Sorry about that. I'll need to update that, but thank you. Sorry.
It was just a whimsical observation, nothing more. It's not a problem.
Thank you.
Thank you very much. Okay. Do we have any further questions on that agenda? Right. I'm sure we can all say thank you very much to Rebecca for that, and to Lucy as well. So thank you very, very much for the information you've provided to us today. Very helpful. And we look forward to whatever gaps that, questions that we have asked that we haven't received answers for in due course. And we will be in touch. Definitely. Thank you so much. Right. Going straight on to agenda item number 9. It's refreshing the partnership's 5-year strategy and developing an improvement approach to our delivery. Obviously, with the new partnership and with the new ICB as well, we would need to know what our role will be on there in terms of partnerships and our involvement. And it would be good to get onto the whole strategy being refreshed and us knowing exactly where we're at and where we're going to. So who is presenting that, please?
That's Esther, Chair, Esther Ashman.
Esther, oh yeah, I can see you smiling. Thank you very much for joining us. Over to you.
Thank you, Chair, and thank you very much for the time on your agenda today. I know you've had some really important discussions, so it was good that we were able to be here. And apologies from Ian Holmes, the Director of Strategy and Partnerships. Unfortunately, he's not well today, otherwise he would have been here as well. So a second apology for the very long paper you received, but hopefully has given you a good background of what I want to talk to you about. So I'm Esther Ashman. I'm the Associate Director for Strategy and Partnerships for the West Yorkshire Integrated Care Board, and I'm leading on the refresh of our 5-year strategy over the next few months. And we have been doing this, as you'll see from the paper, since March. So I know it's a very long paper, so I just want to go through a few key points in the paper and assume that you've had the opportunity to read it. And I know that Mike very kindly shared with you a Health Watch Insight report that was considered at our partnership board alongside this strategy report. And then I do have one slide to go through after a little bit, if it's okay, Bella, for allowing me to be able to share that. So as you'll be aware, now that we've moved into our statutory arrangements, we have a requirement to develop or refresh a 5-year strategy. And I do say develop or refresh because quite a lot of integrated care systems up and down the country don't yet have a strategy or a plan in place. So we're in a really strong position in West Yorkshire in having some really strong, mature arrangements and relationships through our partnership, but also a strong plan that we have previously developed. So we're taking a bit of a different approach to how we do this time. Instead of just sort of going into a dark room, writing something and taking it through the governance groups and taking some of the insight from Health Watch as well, we've pulled together a strategy design group of which we've got representatives from across all of the organisations and sectors that are represented on our partnership board. So it really reflects the breadth of our partnership, and through which we're actually also trying to build some systems leadership and development so that we create a bit of a movement as to how we support a new way of working in our delivery framework going forward. So that group's got representatives from our places, from Health Watch, from the voluntary and community sector, from the acute trusts and the collaboratives that you've been hearing about today, from the combined authority. It's really quite broad and is getting quite far and wide. So we've co-designed the process of refreshing the strategy with this group, and they've been out engaging in their own individual systems, their areas of influence, in both formal and informal groups and individual conversations with people, so that we can really reach far and wide and get as many voices as possible into this refresh and getting as close to the front line as possible. We've had some great discussions in the last week with some of the health and wellbeing boards as well, which has been a really important step given they're the foundation of our strategy. It's really built from places, and we're meeting with the rest over the next few weeks. And we also discussed the progress of the work at Partnership Board on Tuesday. The paper you've got today was shared with them, and they've got the statutory duty for the strategy. And they were really supportive of the progress to date, which was good. And we had some really helpful comments back as well. Much of the planned engagement has actually led on to further engagement as well as a result of the discussions, people wanting to take it out further and further. And I think that's a real sign of the interest that doing it in a different way has created. And it's got a bit of a desire for people to be part of the movement, which is fantastic. It's also worth saying that group's evolving and growing, which is a sign of the process we're using really helping us to try and get to the system we want to be able to deliver our strategy. So as you'll be aware, as an integrated care system, we do have a plan in place. We published that just before the pandemic started. And this plan was co-produced across the health and care system in West Yorkshire, and it responded to detailed citizen engagement that we carried out in response to the NHS long-term plan. It's not an NHS-focused plan. It includes the NHS, but it also reflects the wider system we're working in, as illustrated by the membership of our partnership board, which is something that not all areas up and down the country have got to. We're in a good position with who we're working with, and we're trying to be as inclusive as possible because we really do understand the impact that other areas such as housing and economics and sort of the economy and development and housing and health and trauma-informed services really have an impact on some of the health and well-being of our population. It sets out our 10 big ambitions. As you'll be aware, we collectively agreed and committed to those back in 2019, and it'll be really important for us to ensure that those ambitions are reflected across the breadth of our partnership to make sure that we can make sure that the delivery of the work it sort of leads to collectively making a real difference in reducing health inequalities. So we've heard loud and clear that those 10 big ambitions are still relevant through the process that we've undertaken. And we've sort of been asked, really, please do not move away from them. And it has to be said, the data and evidence that we're gleaning as part of this process is really supporting this. And the context that we've had over the last couple of years with the pandemic has really heightened some of those ambitions. So when you look at some of the mental health related ones, the suicide reduction and prevention, and some of the areas around poverty and health inequalities have really become far more prominent problems. And so it's not a case of us moving away from the ambitions we've committed to. If anything, it's trying to make those stronger. So given all of that, the process that we're undertaking is more about sort of having a refresh of the strategy we're in place. So sort of 20% of our work is around refreshing that strategy. But 80% of the work is more about how we work differently in future to make sure that we deliver that strategy and make sure that we can really measure and feel the impact it's having on our populations. And we know that's something we do need to get a bit better on. And the strategy is really high level. It's a North Star document, if you like. The detail and the action around those ambitions, setting out what we will be able to do to deliver, will be set out in what we call the joint forward plan, for which we're expecting guidance next month to start this work on the joint forward plan. So with that in mind, I do just have one slide I'd like to share. So I'll just check if I'm able to do that. Just bear with me a moment.
Yes, you can.
Okay, can you see that slide?
Yes, we can.
Fabulous. So this is just, it's in the paper as well, but just thought I'd share it to talk through it. And this really gives you an indication of how we're nesting plans and priorities, how we're trying to bring everything together. The NHS, we do like to have a lot of guidance around producing things and planning for things. And what we want to do is to get to the point where everything knits in the right way so that we're all working to deliver the strategy. So on the left-hand side, in terms of the strategic documents that we have, the strategy we develop, at West Yorkshire, the Integrated Care Partnership, which we call the Partnership Board, has to develop the Integrated Care Strategy. That will have a mixture of things that NHS England tell us we really must do. So the things you would expect around elective care, recovery, cancer weights, those kind of things. Then also the things that we know are right for the people of West Yorkshire, so our 10 big ambitions as well. So it's a real mix of those two things and quite a balance to be able to make sure that you can cover both. And there's sort of, in terms of our places, it's built from our place health and wellbeing strategies. And that's really important because that's built on the joint strategic needs assessments and the needs of our population and community and place level as well. Where we get into, and we will be getting into in the autumn, is around the delivery. So there is a requirement for the Integrated Care Board from October onwards to develop a joint forward plan. And that joint forward plan has to illustrate the delivery of the NHS elements of our integrated care strategy. So that will cover sort of how we're going to deliver as much as possible of that strategy. We need to be able to make sure that it aligns to the operational planning we do each year, our Better Care Fund, our winter plans, our financial planning, so that they all knit together to tell a story about how we'll actually tangibly deliver that integrated care strategy. And equally, that needs to be demonstrated down in place as well in terms of how they're planning to deliver against those things that are in the strategy, whether they be the things that we're being asked to do by NHS England that we would obviously also want to do, the 10 big ambitions, and then equally some of the things that are particular for that individual place as well. So those 4 boxes there really do need to try and knit and nest together a bit like a Russian doll. Then on the right-hand side, and these are really important, is the bits that will support the delivery of that. These are the critical bits for success, if you like, and I've heard that through some of the conversations this morning in terms of workforce as an example. So we need to have a strong finance strategy that doesn't lead what we do, but supports what we do. And through the strategy refresh process, you know, our voluntary and community sector colleagues have really given us some support into making sure that we can think about the bits about the voluntary and community sector as an example in terms of the finance strategy. So some really strong links coming through to the development of those. It's really important we have a strong people strategy. Again, like I said, that's come through a lot of the conversations this morning, but equally there are a number of areas where that's important, and it's important to put people at the centre of our strategies. The digital strategy is equally important, making sure that we're tackling digital inclusion, some of those things, the sharing of information, our involvement framework to make sure that we're really getting out there and listening to people to make sure that we can understand the impact we're making, and then the equality, diversity and inclusion strategy as well. So just wanted to show you that diagram because that's quite an important diagram to just illustrate how things knit together. So in terms of all of that information, the insight that you've got in the paper, in terms of coming back from our people, our partners, the data, what we think it's starting to mean for our strategy is that it won't surprise you to know in all our conversations, tackling poverty and the cost of living crisis is coming through very loud and strong, and the impact it's having on people's health and well-being. So we need to make sure that's really embedded through our 10 big ambitions to drive action. We know we're going to need to strengthen our children, young people and families' ambitions to make sure that's focused on poverty, but also access to services, crisis services, SEND assessments, things like that. We want to refine the climate change ambition as well to make sure we keep some of the ambition, but we make it more reflective of how we want to work in West Yorkshire, and we make it more tangible so that we can really make some progress. We want to make sure that it's really focused in terms of a poverty-informed strategy and also taking a life course approach. And that includes commitment to having good end-of-life care as well. And then we have a broader ambition about access. So we know that's coming out loud and strong in terms of GP services, dental services, but there's also sort of the access to the services that our Integrated Care Board is going to take on responsibility for in the lifetime of the strategy. So dental, optometry, community pharmacy, and some bits of specialised commissioning. Some of those things are coming next year, some the year after, and we need to make sure that's factored into our strategy. And then also just having those enabling strategies which will support delivery of that overall North Star document, if you like, and build a sustainable health and care system for West Yorkshire. So I'll stop there and take any question. I'm conscious it was a very long paper, so I just wanted to highlight some of the areas that you might be interested in.
Thank you very much, Rebecca, for that presentation. Already I can see a few hands there, but the first thing I would like to pick out from the strategy, the proposals to refresh your strategy is we don't seem to see any reference to the involvement of JOSC on there or any place-based health scrutiny. So really, I would like to know what our role will be going forward.
So this is more about the development of the strategy and how that will look, which is why we're here today as part of that process, to just check whether you think what's coming out is right, and whether there's anything that you would recommend we do as part of the process. But obviously Just will continue to have an important role in supporting us in the overview and of sort of the areas that we need to include in that, particularly the joint forward plan. I think there will be a role around the developing the action. This is the ambition bit, and then the action bit that's coming from October onwards. We'll be starting that work. We haven't had the guidance on that yet due to sort of everything that's been happening in the political sphere. So there will absolutely be a role for us to come and speak to Josk and for you to help us with some of those areas that will be included in that. And then an ongoing role as part of our involvement framework of helping us understand the impact that it's making as well. Absolutely will be a really important piece of this, but we focused less on the governance type bits and how we get the involvement on an ongoing basis in this, and more about the ambition.
Excellent. Okay, that's reassuring to know. Thank you very much. Councillor Blackburn, over to you.
Thank you, Chair, and thank you, Esther, for a really comprehensive report. I'd like to focus in on ambition number 5, which is the reduction in suicide rates. I think it's a real important one. And I just wondered, first of all, are these ambitions in priority, first of all? And secondly, I suppose what I'd like to know is you suggested a reduction in targeted areas. What are those targeted areas? Is it area based, or is it purely just focused on something else? And the other element, just on your last slide, you mentioned about your digital strategy. I'm keen that we take people along the journey, and actually we presume that everyone uses technology and has the ability to use technology. So I'm keen that actually part of that digital strategy is making sure that we take people along the journey and we don't miss people out, I guess. So thank you for those different points.
Thank you. And absolutely, the ambitions are not ranked in any kind of order. That's certainly not the case. And it's timely to talk about the reduction in suicide, given I think it's the 10th, isn't it? Tomorrow? No, it's Saturday is the sort of day to reflect on that. We're going to be doing some work actually with some of our suicide reduction leads across West Yorkshire in the coming weeks around the refresh of the strategy. So because we know that there is a lot of work to be done, and the data that's coming through is quite stark. But we know there's a lot of good work out there that's happening across local authorities, across the NHS, across some of our voluntary sector groups and community groups. So it's about how we can connect all of that together and have a really good narrative around what we want to do, but also some tangible action. At the moment, as I said, this bit is the working out what we want to do. The action bit is going to be the really important step. I mean, we've been working on this since March and it's felt quite tough going, but the next bit is going to be the really important bit. So as part of our original plan, we had a set of targets, we had metrics. The important bit here is that we relook at the metrics as a result of this work to check, are they the right things? Do we need to refine them? Are they actually, are they realistic? And are they telling us, are they going to sort of really tie in with some impact that will be felt? And then that will then form sort of some of the basis of the joint forward plan of, if that's what we want to get to, how are we going to get there? In terms of the targeted areas, there will be, I wouldn't like to give some specifics around the suicide reduction area because that conversation is coming. But obviously we do need to make sure that there are some it's more about sort of some of the groups that we might want to target a little bit better to make sure that the action we take fits in the right way. And then lastly, in terms of the digital strategy, we have got representatives from the digital group who sit on the strategy refresh work. And my colleague and I actually went to the Digital Leads Forum to talk about the refresh of the strategy, because this is really important. But equally, as you say, it's not everyone has or wants to use digital means. So we do need to really have that in our sights and tell a good story and be able to do it in the right way and offer the right choice for how people do things. So, you know, using innovation is wonderful, and we need to continue to pursue that, but also other methods. We need to make sure that we continue to do that.
Okay, thank you very much. Councillor Smage.
Thank you. You mentioned, I've got a few points, so I'll be really quick, hopefully. Access to GPs. This is really key. And the telephone triage. I'm wondering if it's something that if you are maybe you're of a certain age, or if you've got some complex conditions, or if you have difficulty talking on the telephone, then maybe there should be something in the access that actually you get a GP appointment. Because instead of having to fight for one, because a lot of people are having to actually fight for seeing a GP and getting through that triage. And when you're not well, if you haven't got somebody to speak for you, when you're not well, it's not something that you really want to be doing, is it? Fighting for seeing a GP. So I wonder if there is some work around how to make that far more accessible for people, rather than having those problems. On your ambitions, I noticed you don't have any, do you call them metrics on ambition 4? So you've just got increase early diagnosis for cancer, and I just wonder where those conversations are. I was also going to ask about, is ambition 5 ambitious enough? Yes. And you were talking about targeting groups. Well, if it's a 5-year strategy, what happens if there is another group that's not in the strategy that during those 5 years actually needs some support? How flexible is it? And also you talked about health inequalities, but you don't say how you're going to work with other people on the health inequalities, because everybody's working on health inequalities and nobody can do it in isolation. Everybody has to work together. And so how are you as a health body going to work with all the partners across the board? I didn't see that in the strategy. Thank you.
Okay, thank you very much, Councillor Smage. Some really good points there. In terms of access to GPs, I mean, clearly that is going to be a huge part of our work, and that will, the detailed work around what we can do to improve that will come as part of the delivery plan for those kind of services, as part of the development of the joint forward plan. Funnily enough, I was talking to our primary care lead this morning about exactly that. But that's I can take that back into that programme to make sure that that's taken into consideration as part of the joint forward plan work, because you're right, it's come out very strongly, not just in our citizen insight, but also from our partners as well. So that's a really important point. In terms of ambition 4 and the early diagnosis, so there are metrics that sit behind each of these currently. So our partnership board paper that went to partnership board in September last year provided an update against all of those 10 big ambitions. We're currently working through the progress, working through a piece of work to see what progress has been made since last September around each of those, to inform that, looking at what the metrics might be going forward for our new rate refresh. And our Cancer Alliance team have been doing a lot of work around that to understand what the issues have been around things like uptakes in screening, and there is some huge impacts around the cost of living in crisis, for example, as to how people can make appointments for screening, how they can get there, afford the transport, all of those kinds of things. So just to assure you, the Cancer Alliance are working on that at the moment, and that will be important for us to be able to detail again that in the forward plan as to how we actually want to do some tangible action to make sure that we can increase early diagnosis. In terms of if another group's not in the strategy, it's a really good point. What we're trying to do is to make sure our strategy is built in a way that is sort of strong in terms of what our ambition is, but has the ability to course correct. So it needs that flexibility. You're absolutely right. If nothing else, the last 2 years has told us that things can change, and we need to be able to make sure that our strategy lives and breathes. It's not just something that's glossy and on the shelf and advertised. It needs to be something that is tangible, and we can make sure that we deliver it. So that course correction bit is so important. The joint forward plan bit, the delivery bit, will have to be refreshed every year. So that also gives us a really good opportunity to be able to refresh our action each year if things have changed. And it will be really important to understand the context of the world we're living in each year. And that's why it's so important to anchor it into places, because places have the really good understanding of the local population and the local need. So those joint strategic needs assessments will be so important for us understanding that action over the coming years. And in terms of health inequalities, we have a number of people on our strategy design group who lead on health inequalities, and that's from across the partnership. That's not just health organisations, and our directors of public health certainly are front and centre within that work as well. The bit about how we can have some collective action, again, that'll be the joint forward plan that will describe some of that. And you're right, there needs to be some nitty-gritty in it, and it needs to be about how we collectively work. And that's the strength of our partnership, isn't it? That we have so many different types of organisations that come together in a different way. We have housing organisations that do an awful lot around reducing health inequalities as an example. So we need to try and bring that collective resource together to do something meaningful.
Okay, thank you. I think Scrutiny ought to be holding you to account to say, have you done what you said you would do? And I can see those delivery plans being key in that holding to account. Thank you.
I completely agree, yeah.
Thank you. Thank you very much. Points well made. Thanks. Councillor Hutchinson.
Thank you, Chair. A couple of points, if I may. Like several of the other members of this board, we had the joy of scrutinising the original 5-year strategy, for which we were given very, very little time to actually see, between seeing the draft and having to actually sort of comment on it, not at a formative stage. And I would make a plea that when the draft is available, that we can tie that into the scrutiny programme, so that we can sort of do it justice at a formative stage. But I guess I don't know if a joint forward plan ever emerged after the first 5-year strategy, because the pandemic was upon us. But to my mind, it's that joint forward plan that will really require careful scrutiny, both at West Yorkshire level, but also at place level, and needs to be fitted into the scrutiny programme accordingly. There were a number of omissions, or that I felt were omissions from the previous strategy. And if there's too much cutting and pasting, then I can see those omissions persisting through into the new strategy. One of the most obvious ones is this is supposed to be an integrated care system for health and care. Well, social care only merited 2 pages out of 173 in the last strategy, and that was mainly saying that the lack of council funding meant that they were unable to deliver social care. So I'd like to, this is very obviously a process that is being driven by NHS England, and social care just doesn't seem to get a look into it. So I would like to see that refreshed and augmented and really brought into the full mix. Similarly, there was no mention anywhere in the last strategy of district nurses. They seem to be consistently written out of the NHS at a time when they're most needed, particularly for supporting people with complex clinical problems in their own homes, and end-of-life care as well. And it seems to me, I can't understand why they're being ignored, sidelined, and the specialty being allowed to wither on the vine. The supporting work program, I think, is really, really important. And as you've said, workforce needs to feature very, very strongly. We've said access to GPs is important, but that's got two dimensions. If somebody who's normally well becomes unwell, often their key need is to get speed of access to somebody who can, any professional who can actually get their diagnosis and treatment underway promptly. But for those people who have continuing healthcare problems, chronic conditions, or relapsing conditions, continuity of care is often trumps the seeing somebody promptly. It's consistently seeing the same person that you can follow a treatment plan. And I think that really does need to be recognised in the access to GPs part of your work. So I wondered if you had any comments that before I come back to my final point.
Thank you for that, Councillor Hutchinson. That's some really good points there. I completely agree about you having oversight of both the strategy and the joint forward plan in the formative stages. I know that sometimes the timescales we're given can be really challenging, which doesn't help the situation. So in terms of the strategy itself, we have to get a draft of that into NHS England in December, and that's for publication in March. So even once it's gone to NHS England in draft, there is still much opportunity for refinements leading up to March next year, but we will happily bring something back in its draft stage that we would really appreciate your oversight and scrutiny of that at that point. In terms of the joint forward plan, as I said, we've not got the guidance out yet, although we are using obviously a lot of the work that we're doing in terms of the strategy to help inform some of that, and then there will be some really true consultation and involvement processes around the joint forward plan. We don't have to get a draft of that into NHS England until mid-February, and then it needs to be published by March. They are still very challenging deadlines. However, I'm confident that we will be able to make sure that we can fit it into your work plan, as you said, both at West Yorkshire and at Place, because both will come from a slightly different angle and have and that will bring something different to the process. So I'm sure we can do that, and I can work with Mike to make sure that that happens. In terms of the joint forward plan bit in scrutiny, absolutely, as I said, that in terms of the strategy, we will be able to fit that in. In terms of the omissions from the previous strategy, social care, absolutely, you're right, that needs to be front and centre with everything else in the strategy, and that is our intention. I've got a meeting coming up with some care providers as an example. We're trying to really reach as many people in our integrated system as possible for that reason, so that we can tell the story of how it all fits together and how we want it to be different in the future. And involving social care and social care providers in that is so important. And we know that's there are a lot of challenges around that, and it's not just around funding. There are other challenges, and we need to make sure that they're reflected in our strategy. In terms of district nurses, and I would imagine a lot of that will be reflected in some of our neighbourhood working and our community working, and how we describe that integration at neighbourhood level, and that will form some of that. So they absolutely will not be written out of any strategy or plan. They are a key part of our workforce that it's really important to make sure that they're included. In terms of continuity of care, I think some of that will fall into, as I said, the delivery plan around primary care access, whether that be GPs or other health professionals. So that will be a part of the joint forward plan development. But I completely understand your concerns around that. And that's something I'll take back to our primary care lead, so that they make sure that that is included in those conversations around the delivery plan with that.
Okay, I would welcome some acknowledgement of district nursing within the strategy, because as I said, in every document over the last 5 years, it's been totally blanked, both at local and at regional levels.
Sorry, Councillor Hutchinson, just before your last comment, are we able to hear from Councillor Harrington and Ramsey? Councillor Ramsey has not spoken at all today, so I would really like to hear from her, and then I'll come back to you if we still have time, because I'm conscious of time. We need to finish by 12 noon, if that's all right. Councillor Harrington, please.
Okay, so it's about dentistry, Esther. So obviously there's a lot of areas within West Yorkshire that have problems with dentistry, and I know that you said that the responsibility doesn't actually come until next year, but what plans are we looking at now for that, and how do we think we're going to develop that? Because it is a major concern, certainly within the Leeds City Council areas, and I'm sure it is across most of the other West Yorkshire areas. Thank you.
Thank you, Councillor Harrington. I was expecting we might get something asked around dentistry, because it is something that's coming out of all of the conversations that we're having with stakeholders and partners. We are currently working with NHS England, who commission it at the moment, to sort of have a plan for that delegation next year, as you would expect. And our primary care lead in our integrated care board, who you'd expect would be part of those conversations, is not there on her own. I'm there from a strategy point of view for that very reason of how we make sure we think of the future. We do have a bit about how we get to the point of the sort of the operating model, the contractual bits. We need to plan for those, but then alongside that, there needs to also be the plan for the future then. So what we are making sure we do is that we are sitting in those conversations now over the next few months, so that it's not just a one ends, one starts, that we're working together so that we're planning for the future and planning for that transformation. Obviously, there are challenges and there are finite resources, but that doesn't mean we can't start to think about the future and how we can plan for a good future for dentistry services for West Yorkshire. I had a conversation yesterday with a child oral health lead, because that's another issue we need to make sure we consider in the strategy as well, because child oral health is a real issue in West Yorkshire. So it absolutely is high on our agenda, and it would be great if we could, we might come back to this scrutiny group at the right point to be able to get your help with that as well, because you've clearly got a lot of really helpful insight that would support us in that.
Thank you, Esther. We'll hold you accountable to that. Thank you very much. Councillor Ramsey.
Thank you very much, Esther, and thank you as well, Councillor Harrington, for asking about dentistry, because that was on my list. I only had two. One was dentistry, you've covered. You did talk about the voluntary sector and how you're engaging with them, and it always worries me a little bit as somebody who works in the voluntary sector that it's a cheap option. I think there are fantastic voluntary organisations who are really willing to do great work, but it can't ever be considered as part of the basic pathways. And I just wanted to just explore what you were thinking there. Unfortunately, you mentioned it at the same time as you mentioned the financial strategy, and that did cause me concern.
Thank you, Councillor Ramsey. And I just want to assure you that the reason I mentioned it in the same breath as the finance strategy is because I actually went out to quite a lot of the discussions with the voluntary and community sector with Joe Baker, our Harnessing the Power of Communities lead, and they were incredibly articulate about what they had to offer and what their challenges were and the barriers were. And the reason I mentioned the finance strategy is because some of what they were saying is, you know, when we're there when the decisions are made around finances and it's too late. And so I was pleading with them, be involved in the development of the finance strategy, because that's where you can start to build some of the support for a sustainable future around finances, which is what they've done. They've developed some principles around commissioning and finances, which they're working with the Director of Finance on as part of that process at the moment. So it wasn't that I was wanting to put monetary values on it. It was more about how we make sure sure we can help create a sustainable future, because they are a hugely important part of our infrastructure and our workforce, and they bring something very unique in terms of the knowledge of communities and their ability to be able to work with communities in a way that perhaps not all of us can. So absolutely, they are a huge part of this strategy. I very much enjoyed all of the engagement that I did with Joe with the groups, because they really had a desire to make sure that we can make this strategy different for the sector and for what it can offer. So hopefully that answers a little bit of your question, but I would be very happy for any groups that people would like us to go and talk to. Very happy to do that.
Okay, that's great to know, Esther. Thank you very much. I believe Councillor Hutchinson, you still had one more. Is it question or comment?
A bit of each, actually. It's really about how attainable are the goals to address health inequalities. One of the chief executives of NHS England, Lord Crisp, his latest book was called Health is Made at Home, Hospitals Are for Repairs. And essentially, we know that a large proportion of the problems outlined in the ambitions require us to tackle insecure, poor quality, poorly paid jobs, insecure, poor quality housing, insecure access to poor quality food, unsafe communities, and poor educational inclusion and support. I really don't think the integrated care system should be accepting responsibility for the task of solving our highly unequal society and the problems that flow from it. Certainly, it can be involved in making sure that those communities and individuals that are most deprived don't face barriers in accessing good quality healthcare, that it's located and provided in those areas that most need it, rather than those that are most desirable to live in, or where people are more articulate and can lobby for better healthcare. But saying that the National Health Service should be a health service, it can't be tasked with addressing all the problems of our society. We don't have the levers to be able to pull to make these things happen. And so I have concerns about the way that some of these ambitions are being expressed.
Thank you, Councillor Hutchinson. It's really tricky, isn't it? Because we know a lot of these things massively impact on health and care, people's health and well-being, and so it's how much of the resources do you put into the things that you can tangibly make a difference in. So I understand what you're saying. We had a session of our group a few weeks ago where it was led by one of our consultants in public health around poverty, and thinking about all the different elements of poverty and what tangible action we can make. And as you'd expect, a lot of that did come back to health services. So how people can afford transport to get to health services, something you talked about earlier, how people can make sure that they have a warm home so as not to impact on their long-term conditions and respiratory illnesses. And we know we can't necessarily make a huge difference on some national policy around housing, but we can use our collective power of influence around some things, or try and help where we can. But I do agree it is a balance, but we can't ignore those things because they have such a huge impact on health and well-being of our population. And I think, our ethos of working together to make a difference really, it helps with that. So if I think about some of our programmes across West Yorkshire, having housing coordinators in hospitals to support people getting back home into a home in the right way, which will sort of help with our discharge and our flow through hospitals. So there are some really huge benefits to the health system through working with some of our partners on these things. But you're right, there is a bit of a balance of where we target our resources. I do understand that.
Okay, thank you very, very much. And I think we all will agree that Esther's done a very good presentation today and given us a good overview of what we need to know going forward, especially with the strategy. And at least I'm quite pleased that we're still involved and we can still remember we're only critical friends. So I know you've been barged with lots of questions today and comment, but it's from a good heart from ourselves. And we have a lot ahead of us, especially, you know, with our role as scrutiny chairs for health. Very, very important time in our lives and all this going on. So we really, really do care. And that's the only reason why we're throwing all these questions at you. So please take it from a good place. And we do look forward to working with you and being involved with everything that you do in Wyatt, and say thank you to the rest of the team on our behalf. So thank you very much. Last on our agenda now is our future meetings. Esther, you're free to stay if you want to hear the rest of our dates. If not, have a lovely day. Thank you very much. So back to you, Mike.
Very briefly, Chair, thank you. In our previous discussions, we've identified dentistry and oral health and access to dentistry, and as one item for the November meeting, and a second item for hearing from the Yorkshire Ambulance Service about the demands on their services at the moment. And this morning you have